It's Dr. Naveen Keller here again with Dr. Sandip Rao, and I just got back from AUA in Washington, D.C. last week. It was really eventful. One of the things that really was impactful, in my opinion, was the new guidelines for BPH that came out. And the AUA has guidelines for lots of different disease processes. With BPH, we have different levels, and it's grade A, grade B, grade C. And PAE has been part of the guidelines since 2023, and it had a grade C designation. Well, at this year's AUA, it increased to grade B. Basically, grade B means that there's a lot of evidence suggesting that this is a good treatment option for BPH, although there could be more evidence that could come out, which could push the efficacy or the ability of the treatment to treat BPH even higher or perhaps worse. Grade A, there's only one grade A treatment for BPH right now, and that's TURP, which has been backed by decades of experience. So, yeah, so grade B now for brings it in line with therapies. I think it's just remarkable how far PAE has come along.
No, absolutely. I think this endorsement from the American Urological Association is going to serve as a big game changer, not just because it supports what we're currently doing, but also this should also give a lot more credence for patients to get this patient covered and paid for. So I think the big change is as what you just said. It went from being somewhat of a classified as an investigational only to a recommendation. Now, does have some conditions to it, but I think it's definitely a huge move in the step in the right direction. I think it really comes down to a few different things. That there's some studies out there which we've discussed in the past, but I think it really comes down to a couple major studies. One was there's this large, that's like a single blind study comparing the prostate artery embolization to a sham procedure. They found improvement in the key scores, the IPSS score, showing improvement in voiding and urination. They found also volume reductions as well. And then there's a large series that was produced by Doc down in Miami, Dr. Bhatia's group. They did about 1,000 of these procedures, kept track of it over a very long period of time. And I think that also is just serves as, even though it is a single center study, a lot of
Mhm.
great information that we can get out of that. He looked at the procedure from multiple time standpoints, looking at prostate artery embolization initially at 3 months, 6 months, even going out to 4 to 6 years out. And I think in every one of those time intervals, we found a sustained level of improvement in these men who had enlarged prostates. They were able to still keep their urinary frequency, their urgency, those able to be reduced, decreased patient straining. So I think those are some of the key things that really helped, I think, move the needle, because it for a while had not really probably seen this as somewhat of a competing procedure to what's currently out there. But I think now slowly it's coming up to where they consider it, with all these other minimally invasive therapies that are out there, on par with a lot of these other things that we have.
Yeah, the AUA guidelines are really impactful. It's not in a void either. Society for Interventional Radiology, I know you guys have had it as part of the guidelines for a while, but when different specialties come together in a positive way for a technology such as PAE, it will make an impact on insurance coverage, which has been a problem a lot of times for patients who are interested but find out their insurance won't cover the procedure. You mentioned that I made some. I looked at that Bhatia, Dr. Bhatia study, that 1,000 patient study where these were basically his patients, and he did a retrospective look at these patients to look at their long-term outcome, and it mirrors what we see with these patients when, for example, you treat them. The safety, I think, is paramount, and really, in his series of 1,000 patients, less than 1% of patients had any real serious adverse events. A few people became septic after the procedure, and a couple patients required a TURP after the procedure. and no one had any sort of embolization of surrounding structures where they had a problem, like a penile embolization or rectal embolization, which is what I'm always concerned about. And then as far as another big thing, which is how often do these guys need some other sort of therapy after the PA is completed? It was only 16% in this series, which is, I think, lower than what we as urologists have read, but it might be because this is a technology now that is becoming more, the technology's improved, the catheters, I think, are smaller, as you've said before, the imaging is better. And so obviously the results will be better, just like we've seen in our and when we do robotic surgery, our results are better than when we did open surgery for prostate cancer. So that's what I was really impressed by is the low rate of having to get another procedure done. It was 16% in his experience, and then the safety, and then of course the sexual function. He was able to preserve sexual function in all these patients.
No, for sure. I think a large group of your patients also, they might come in catheter dependent. They come in, they have a need to have a urinary catheter, Foley catheter. But what I really liked about his paper was it showed, I think it was almost 94%. I don't have the raw numbers here in front of me, but I think 90 in the mid 90s, these patients were catheter free at 3 months, which is a huge deal because a lot of these men, you don't want to be tied to having this good catheter, and it significantly improves your life, especially if you're in that dire state where you need a Foley catheter to be able to urinate. So I think that's also another key finding that was in the paper.
I would 100% agree because when we have those patients who come in and they're in retention from the emergency room or they've been referred by a rehab facility and they're unable to urinate, a lot of times they're not in great medical condition to undergo a TURP, or sometimes they're anticoagulated as well. And these are the patients we definitely want the catheter out. And to see that within 3 months, there's such a high rate of patients who are successfully able to get rid of their catheter and void again after their PAE. I think that is really big because that has always been a troublesome area for us when we're trying to get patients catheter free, but their medical conditions are making it difficult for us to do conventional surgery for sure.
No, absolutely. And I think another key thing was patients oftentimes come and ask me, if I get this prostate artery embolization with you, what's the chances that you have to go back in again? And I think this large study showed the reintervention rate was about 16% at about 60 months. So the thing that I always tell folks is it's a very minimally invasive procedure. I personally like going in through the wrist when I do the PAE. You can also go through the groin, but you come in, you get the procedure done, takes about an hour plus or minus. You go home within the hour. Now, if you had to get this done again in 5 years down the road, most people would not balk at that. They'd be totally okay because it's a very minimally invasive procedure that we do know the prostate, even despite us putting this medication, blocking off the flow to it, it might want to get bigger over time. And so, despite the fact that it would possibly do that, we can always go back in and retreat it as needed.
No, that's really good. Yeah, I just glad we're able to get together to talk about this.
For sure.
Really big news from AUA and the guidelines of moving PAE to level B based on like evidence that we just talked about with this paper. So look forward to talking to you more about the PAE, and we'll see you soon.
Great. Thanks, Dr. Keller.
All right. Thanks a lot, Dr. Rao.